As Marie says, there's so many people coming in from different parts of the world. You're welcome. Welcome to this webinar on adapting treatment and prevention of wasting during the COVID-19 pandemic. Before we go ahead, please note that we have spontaneous translation in French, Spanish, and Arabic. Below your screen, you will see just next to the share screen button, you'll see interpretation. Please do click on that to choose your language of preference. To note, however, is that Zoom does not show Arabic translation, so the translators for Arabic are in the Korean booth. So for you to get the Arabic translation, please go to the Korean language tab. Thank you very much. So this webinar is made possible with support from many of our donors, and these are USAID, UNICEF, Irish Aid, Save the Children International, and today we also do have Elena Cook Foundation. Elena Cook Foundation and Irish Aid are providing support to the ENN, that's Marie and Elson, to support the webinar today. Thank you. So today's webinar is going to cover quite an interesting area of discussions. And during the webinar, we expect that there will be an overview of the wasting brief, which will be presented, including the key adaptations. And then we'll be able to identify the scale of adaptations globally, and we'll demonstrate the specific adaptations in case studies. We'll get case study examples from South Sudan and Somalia. And at the end of it, we'll also give an opportunity for participants to ask questions on the brief and the adaptations in general. Over to you, Marie. Thank you.
Thanks, Martha. If you just move on the slide, please. So what we're going to do is, I'd like to first welcome you all to this webinar, and we'll do a brief introduction in a moment to the presenters that are going to be on the panel today. As Martha says, we're going to have a presentation by Zita on the recently released brief on COVID-19 and child wasting management in facilities, recently released by WHO and UNICEF in collaboration with a range of partners who contributed to the content. And then we're going to go on to some of the an initiative around mapping adaptations in a more comprehensive, rigorous and mindful way, and a call on all of you to engage in that. So we'll have an interesting presentation by Saul and Heather there. We'll then move on to our case studies, and we're going to have a few conversations and interviews with representatives from Concern in South Sudan and Action Against Hunger in Somalia. And you'll be happy to know these are PowerPoint-free presentations, as we wanted to listen and learn rather than read and watch. And so we're looking forward to that. We'll then handle all the questions and answers together for all the panelists and all the presentations. So only urgent clarifications will be addressed after each presentation or conversation, and then we'll have a full discussion after that. Alison, who is working with ENN, she's going to be managing the questions and answers, and so pop your questions in as they come into your head, and we will collate them and address them to the panelists. Any questions that aren't answered will be collated afterwards, and they will be answered by the tech or RT. Any questions that are not straightforward and require a bit more consensus to address will be escalated within the GTAM mechanism, and all of these will be shared with you as follow-up to the meeting. So to give you a quick overview of today's presenters and panelists, and myself and Martha have already introduced ourselves. Martha is a CMM advisor at the Technical ORT. I'm one of the directors at ENN. I also co-chair the Wasting Thematic Working Group of the GTAM. And just touching on my colleague, Alison is a technical associate working with ENN at the moment, is chair of the Wasting and COVID-19 work stream on wasting within that technical working group. We have Zita from WHO, who will present on the brief. We have then Saul from UNICEF and Heather from Action Against Hunger, who will talk about the initiative around programming adaptations. And we then move on to the case studies, and we welcome Lubaba, calling us in from South Sudan, and Sadiq from Somalia. So that's the team on the webinar today. And without further ado, I think we can move on, and I'll hand over to Zita, who's going to present on the recently released brief. Thanks, Zita.
Thank you, Marie, and thank you to the team who've invited me to make this presentation and to participate in this webinar. I will try to briefly explain what is in this new guidance that has been developed by UNICEF and by WHO, and with input from the various partners. I won't be able to go into detail, but all of you should have access to this document and can have a look directly. Next slide, yes. Briefly mention what the scope and purpose of this document is, and then go into the different sections of the document, which is on prevention, on treatment, on strengthening and supporting delivery of services, and there is also an annex on the use of anthropometry, which I'll brief you on briefly. Next slide, please. Yes, so this is really a guidance on supporting the delivery of services through national health systems as mentioned in the prevention, in the early detection and treatment of child wasting in the specific context of COVID-19. Adaptations might be necessary depending on the transmission levels, on population mobility restrictions, on resources, on other national public health measures to respond to mitigate effects of the pandemic. So what we're trying to convey in this guidance is really the focus should be on the continuity of services with IPC, which is infection prevention and control measures that should be in place. Where this is not possible, in certain exceptions, adaptations may be needed on a temporary basis. I did want to highlight, sorry, just to the slide before, I did just want to highlight the two documents, key publications that have been published in June and in May, that are the basis for this current guidance. Next, sorry. The section on prevention, there are three outcomes that were mentioned in the GAP. The GAP is the Global Action Plan on Child Wasting that was published earlier this year. So we looked at the three key outcomes and the actions in the GAP document, and looked and examined and considered these actions in the context of COVID-19. Again, it's not possible to go through with you all the suggestions of possible adaptations that are needed in order to focus on the key actions, but these are very much part of the document under the section of prevention. So there's the improving child health as one of the areas. Next slide. The other outcome under prevention of wasting is to improve maternal nutrition and reduce low birth weight. So again, there we have key actions that we should be focusing on, and what are the considerations that we need to look at in the context of COVID-19. There are examples in the document. Again, due to lack of time, I will not go into detail here. And the third area is improving infant young child feeding. It's around promotion of breastfeeding, appropriate complementary feeding. There's also the vitamin A supplementation for children 6 to 59 months of age. And again, here in settings where the normal actions cannot be carried through because of certain restrictions, what are some of the options that we can consider? Next, please. There's a section on early detection of child wasting through primary and community health platforms. There might be temporary programmatic adaptations that are needed, for example, shifting fully to MUAC, and where weight and height might not be possible to be measured, This again is explained in the document, what such settings are and what are the monitoring conditions that need to be in place. Next. When it comes to inpatient treatment of severe wasting, the focus should really be on ensuring that IPC measures are in place in the stabilization centers and in the wards or the therapeutic feeding centers. It's very difficult to compromise on certain on the principles when it comes to caring for the very sick children who are also severely wasted. And it's important that the health staff have the capacity and the training to do so. Now to the outpatient treatment, again, focus very much on continuing safely the routine services as per national guidelines, but where sometimes in certain settings this is not possible, there might, as mentioned earlier, be a shift, for example, to using MUAC in terms of admission and discharge. There might also be a decision made to expand the cutoff of MUAC when it comes to admission into programs. These are recommended especially in areas where there are no services for the management of moderate wasting. And where this is done, considerations have to be made on the increase in numbers, and also in terms of referral of these children to with medical complications to stabilization centers or to TFCs. We have to be clear that the children with moderate wasting need to be referred to pediatric care. So there's a lot involved, but these are some of the options that can be considered in order to try to expand the number of children included in programs. Regarding management of moderate wasting, this guidance is, as mentioned at the beginning, is focusing only on the health services in health systems, so it's not comprehensive. It does not cover all the areas that were covered in brief number 1. But in terms of health services and the management of moderate wasting, again, focus on IPC measures that need to be in place, and there's certain examples of suggestions for adaptations, for example, reducing the frequency of visits and trying to avoid the mass gatherings where there are programs on distribution of supplementary food, and planning the rations ahead of time so that they can be distributed quickly. These are just really examples. There are a lot more examples in the guidance document. When it comes to the outpatient management of infants, those nutritionally at-risk infants, less than 6 months of age, there is a guidance, a statement that was just published by ENN and partners, which is extremely useful and has a lot of has more information than this guidance document has. But maybe just one point I wanted to pull out is that we do talk about possible use of MUAC thresholds to identify nutritionally at-risk infants. As you know, these thresholds for infants, there's no global guideline on these thresholds, but in this special situation, they may be used. But important to note is that if infants are identified as being nutritionally at risk, there needs to be a very clear pathway to manage such cases. And there's a link there for more information. The section on strengthening systems to support the delivery of services for wasting, we have looked at the different components of the health system strengthening and come up with examples on what needs to be in place and what adaptations can be considered. Again, here, these are just examples around coordination and governance. It's to ensure that wasting is not forgotten, that it's included in the package of health services, also in the context of COVID-19, that the monitoring component is extremely key and that continues. When it comes to financing, it's a matter of trying to protect the funds for essential nutrition actions, especially also for wasting. And not only to protect the funds, but also to try to increase financial resources when it comes to the management of wasting, since we are expecting higher numbers of children who are wasted seeking services. When it comes to the health workforce, it's ensuring that there are enough health staff who are trained, who have the capacity of managing children who are wasted, including not forgetting, of course, the community level and empowering community health volunteers to be very much involved. They can play a very important part, and also the link with households with involvement of caretakers and mothers. Yes, adequate training, equipment, supplies is important. Next. It's important to really focus on pre-positioning the essential commodities for nutrition and have a regular tracking of the supply chains for essential nutrition products. When it comes to health information systems, we really recommend to identify gaps in the reporting of these treatment services, prevention and treatment services, and try to come up with innovative ways of monitoring. There's a lot of discussion around digital technology and how can this be done, and any good examples of this would be extremely useful to share with countries. And also, how can secondary sources of data be captured when it comes to trying to interpret the situation and identifying hotspots. This, no one can read this, but this is an annex in the document. Thank you to the Yemen team for sharing this information with us. It's about we call it the parameters risk matrix, and there are two scenarios that are looked at, either in places where there's availability of protocols, availability of IPC measures where they're in place, and a scenario where these are not in place, so a shortage of IPC material, of disinfectants, and so on. So just one example, again, no time to go through it, but if we look at the parameter weight, and we look at the assessment tool, for example, the digital scale, we would say that in a setting where IPC measures are in place, that digital scales can continue to be used. But also in the second scenario, in places where IPC measures, there might not be enough disinfectants to disinfect the material, digital scales can still be used, because it's not that the child is not put on the scale, it's the child is carried and people step on the scale. So these are just, this is just one example, but there's a list of different equipment and what should be looked at carefully in what scenario. Next slide, please. This is my last slide, and it's again really to emphasize, and I think this is the difference between this guidance note and brief number 1 in terms of health systems, is really to intensify efforts to ensure access to the appropriate equipment and to enable continued services for wasting as per national guidelines and protocols. Thank you. Over.
Thank you very much, Zita. Very interesting and very nice brief on the brief, as it were. Alison, just to ask you, are there any urgent clarifications? I think a few things have come in, but I think they may be discussion points, but just to double check with you.
No urgent clarifications for now.
Fantastic. Right, Martha, I'll hand over to you now.
Good. Thank you, Mary, and thanks to Zita for for the discussion. Right now, we are going to have Sol present to us the different key adaptations that are currently in practice. So, thank you.
Thanks, everybody. Good morning. I don't know if you can see me. I'm just gonna get that started. Yeah, and so to follow up on Zita's summary of the guidance, what we wanted to do with this brief section was to give you a sense of what is happening in practice already, even before this guidance came out, but also what we can therefore expect to happen as you know, as the guidance gets released in terms of seeing programmatic adaptations. And what I want to show you is very briefly a little bit of what we are seeing already from our vantage point, but also some of the systems and processes that we're putting in place in order to continue to both monitor, but also support programmatic adaptations. Next. So the first thing to say really is that National Nutrition Services are not static, right? They're always adapting. There isn't such a thing as a standard way of doing things that is impervious to change. But that process of adaptation has certainly accelerated since the start of the pandemic. Things that were starting to happen with nutrition services, especially those for the prevention, early detection, and treatment of child wasting, we have certainly seen how the pandemic has acted as a catalyst for many of these changes to be introduced, rolled out, or scaled up in many different contexts. Next. So prior to the pandemic, UNICEF had already started to monitor the location and type of adaptations that were being made to services for the early detection and treatment of child wasting. This was largely the result of what we could see happening already, and our desire to make sure that we were in a position to help sort of countries learn from each other. And that the more that some of these programs were adapted, the more that we could generate learning along the way. Now, as the pandemic began and we started to see an acceleration in the adaptations that were happening to early detection and treatment, we really sort of intensified that monitoring plan or effort or process to make sure that we were really in a position to capture as much as we could. Next. And although this sort of monitoring process is still very much work in progress, and I would be lying to you if I told you that right now we can see absolutely everything that is happening at country level, we are certainly starting to get a pretty good picture of what's happening, and this is really what I wanted to show you. Next. So the first thing to say is that we are seeing this sort of process of adaptations to early detection and treatment of child wasting happening quite sort of primarily in both the East and Southern Africa region, as well as the West and Central Africa region. That is, I mean, from our vantage point, that is where a lot of that work is happening. But we are also seeing efforts to adapt services also in East Asia and the Pacific, in Latin America, as well as the Middle East region. So there's starting to be, it's not confined to one region, right? Given that the pandemic is a global event, and that this is affecting services and populations worldwide, we are starting to see these adaptations happening around the world, but with a greater emphasis, perhaps unsurprisingly, in regions where wasting has been historically treated at scale, like the African regions. Next. Now, the other thing that we are starting to track and see is which type of adaptations. As Zita mentioned in the guidance, we really sort of go through a range of adaptations for the early detection, prevention, and treatment. But some of these adaptations we're seeing them take place or being introduced faster or at a larger scale than others. And so what this graph sort of shows you is the number of countries that are implementing specific adaptations. And I'll go into it in a little bit more detail in a second, but there's one main message that I really want to sort of be clear about, because I think that that's the main message with this slide. Next. And that's that adaptations that do not require protocol changes are being rolled out faster than those that imply changes to global protocols or guidelines. And that this is unsurprising, right? Most countries want to adapt, but they don't want to adapt by throwing sort of normative guidelines out the window. They want to adapt to things that are adaptable and that require that where the burden of proof is lower in a way. And those, therefore, a lot of what we're seeing sort of mirrors that. Next. So for example, in the case of family MUAC, which is the process of empowering caregivers to use MUAC bands for the early detection and self-referral of children who are wasted, we are seeing a rapid expansion of this approach across a range of countries. Next. So this isn't a full list, but it gives you a sort of a flavor of where we're seeing it. And I think that there's a couple of things that I wanted to know. First, it's happening in various degrees in various countries, right? So it doesn't mean that it's happening across the entire country, that it might be localized within parts of the country. But the other thing that I wanted to say is that, and I think that this is certainly from my perspective fascinating, is that this sort of covers a range of regions across Western Central Africa, Eastern Southern Africa, as well as places like the Dominican Republic and East Timor, which haven't historically been places where a number of these services have been implemented at scale. Next. Next. Oh, yep. So then we're also seeing more and more reduced visitations. What this means is really caregivers being asked to come for visits to the OTPs not every week or every 2 weeks, but potentially once a month, or potentially if it was weekly, moving to bi-weekly. So these are some of the countries where we're seeing that. And then finally, next. Just a couple of examples of where we are starting to see the rollout of treatment by community health workers. This is, as many of you know, an important area where we're seeing progress. It does require some more careful consideration of national and global guidelines, but we're already starting to see this being introduced or scaled up in a number of countries in order to improve access, given the limitations that there is to accessing health facilities as a result of COVID. Next. So really just a couple of points before I finalize. The first is UNICEF's unique vantage point allows us to really see what's happening around the world, and we want to make sure that we maximize sort of the contribution that we can make from that perspective. But what we're also realizing is that we need to go beyond understanding what is being done where, and we need to really start making sure that we are in a position to explain and articulate a comprehensive answer to how these changes are happening and what happens when these adaptations are being introduced, to go beyond just the surface of being able to monitor it, sort of what's happening where, and really into the so what, right? Like what brought about these adaptations and what is the implication or the impact of these adaptations. Next. And that really is where this partnership between UNICEF, Action Against Hunger, and the Center for Disease Control in Atlanta really comes in. And so I would like to hand it over to my colleague, Heather, who will give us a bit of an insight into what that project will do. Over.
Great. Thanks, Saul, so much. Right, so as Saul mentioned, Action Against Hunger is leading on an effort with support from USAID in close collaboration with UNICEF and the CDC on trying to really maximize our learning around a lot of these adaptations that Saul just presented on in the management of child wasting. Next slide, please. So the effort is really to try to systematically document and analyze and synthesize a variety of information related to these adaptations that are being implemented with objectives to both identify and track the adaptations, which UNICEF has started to do and outlined, but then also just extract learning around what's happening on the ground and the programmatic outcomes. And then also to facilitate uptake of this evidence in as near real time as possible to both inform responses now in COVID-19, but also to help provide evidence for future programming as well. Next slide, please. So there are sort of three main activities that we're engaging in. And the first is sort of a tracking or a mapping, expounding upon what Saul just presented on, to really identify who is doing what where, even trying to get down even beyond just a national level to subnational levels and individual organizations in certain locations. So we're disseminating a survey. We're trying to do that as widely as possible. And we're asking for implementing organizations to fill out the survey to tell us what adaptations that they are implementing. And then we're trying to disseminate that on a publicly accessible website, the State of Acute Malnutrition, which I'll highlight here in a minute. Secondly, we really want to learn what this looks like on the ground. So Action Against Hunger researchers will be conducting semi-structured interviews with program implementers to try and document the lessons learned from the operational implications on the ground, and then disseminate that also in as real time as possible on the State of Acute Malnutrition website. Lastly, we are hoping to gather programmatic data and aggregate it and conduct some pooled analyses to see what are the program outcomes associated with many of these adaptations in the context of COVID-19. And the CDC will be leading on that secondary analysis. Next slide, please. So here's just a brief screenshot of the State of Acute Malnutrition website, where we've created a new page focused on COVID-19 adaptations. And you can see here where we'll have a tracker where we're hoping to highlight what adaptations are being made where. We're also hoping to collect and create case studies and relevant tools that may be used. And we'll also be collaborating with TechRT and GTAM and EN to disseminate further results. Next slide. So this effort will not be successful unless we have collaboration from as many implementing partners as possible. So we are calling people to tell us what you're doing. What is your organization doing on the ground in terms of adapting protocols around the management of wasting? And we have distributed a survey for you to do that. To share your knowledge, if you have case studies or innovations that your organization has implemented or tools that you may have created, share that with us and we'll disseminate it widely for everyone to learn from. And lastly, there is a call for data. We're asking organizations to share your programmatic data with us and we can aggregate that and look at trends. What are we seeing with a lot of these adaptations being put in place? So how can you engage? Please be on the lookout for announcements being circulated widely about this project, to fill out the survey and share your data. But also you can just email us directly at cmamadaptations@actionagainsthunger.org or visit the State of Acute Malnutrition website. So that is all from me. Back to you, Martha.
Thank you very much, Heather, and thank you, Saul. Alison, I don't know if we have any points of clarification at this time after listening to both Saul and Heather.
No urgent points of clarification at this time. We can answer them later.
Thanks again, Saul, and thanks, Heather. Just to remind everyone that please use the Q&A to have all your questions and any points that you'd like clarified. Those will be answered during the Q&A session. And again, a reminder on the interpretation, we have the French and Spanish and Arabic translations. Those looking for Arabic, please use the Korean tab, as Zoom does not have the Arabic tab currently. Thank you very much. I'll hand over to Marie right now to take us through the next session, which is the case studies. Over to you, Marie.
Fantastic, and I know these are the sessions that everyone really has been waiting for. So delighted to introduce Lubaba Hussein, who from Concern South Sudan. Just checking we can see you, Lubaba.
Yes, I'm here.
Fantastic, thank you. So great, and so you're going to share your experiences from South Sudan, and we're going to kick off really with you. If you could just take 2 minutes, really just to tell us a bit about the context in which you're working, where you're working, the type of programming, and what's happening quickly in the context of COVID-19.
Thanks, Mary, for the introduction and also having me for this important webinar. Concern runs an integrated program to treat children, pregnant and lactating women with acute malnutrition. We are focusing on OTP, Stabilization Center, and TSFP. We are working in 3 locations in South Sudan, in 3 states, Unity, Central Equatoria, and Northern Bagazal in South Sudan. So the nutrition services are provided from 72 OTP and TSFP sites and 3 stabilization centers in the 3 locations. And the context is different. Some are in IDP camps, some are in the host community. In 2019, actually above 38,000 individuals were treated in OTP and TSFP in these 3 locations. In addition to the treatment of acute malnutrition, we also run community nutrition activities on behavior change communication through mother-to-mother support groups. We train mothers, and the mothers are cascading the MIYSN message to the community. In terms of in COVID-19 context, when the first cases were identified in the country, access was restricted to the IDP camps, especially from the capital. International and in-country flights were cancelled. Meetings were banned by the government. However, some of the restrictions lifted with proper IPC measures later. Currently, by the 3rd of August 2020, 2,450 confirmed cases reported in the country, and with 47 days. The figure looks really low. Maybe the infection rate is low, or maybe because of the low testing capacity.
Great, thank you. We've set the scene very nicely, Lubaba. So in that context, what sort of adaptations have you made to keep the services you're supporting going, and have any of the services needed to stop?
Actually, we continued most of our services with some adaptations, but we also suspended a few activities. Let me start with the adaptations. The IPC measures were in place in all nutrition sites. That includes maintaining the 2-meter distance in the nutrition sites. This was done by marking the sitting and standing places. We also established hand washing facilities as the entrance. We used to have hand washing facilities in the center, but it was not really as the entrance. But now all people who are accessing the nutrition site, they wash their hands. And also there is temperature screening at the gates. If a person who have high temperature will be isolated and also will be referred to the health facility for checkup. We also include risk communication, especially the COVID-19 messaging on the signs and symptoms, and also the preventive measures. All the IYCF message also integrated with COVID messages, actually. All information is like with the context of COVID. We also increase the number of days for OTP and TSFP. For example, we used to have 1 day for TSFP, but now we divided our beneficiaries to reduce the gatherings, to reduce the crowd in the nutrition site. And we have manageable number every time. We also shift our admission criteria to MUAC and ODEMA only. We dropped weight for height Z-score admission. But the MOAC cutoff is still the same. There is no change. But discussion is ongoing at nutrition cluster level with UNICEF and WFP to expand the MOAC criteria, but it's not yet decided. We also introduced family MOAC as presented by, I think, Zita or Sol. This family MOAC is a new approach for us. It is because of COVID-19. We train mothers to measure their own children. We train mothers who are in the program and also who are not in the program with children under 5. So they will be given MOAC tapes. That MOAC tape will be used only in that family. So far we managed to train a good number of mothers. Majority of them are OTP-TSFP beneficiaries, but we also managed to train some mothers in the community for screening and referral. So these mothers are the ones measuring their own children with the support of our staff. We also reduced the frequency of the visits as presented by the previous presenter. The weekly OTP is now changed to bi-weekly. The bi-weekly TSFP is now monthly, so we also reduce the frequency. In the absence of weight measurement, also the ration size for OTP is based on MOAC. Previously, children used to receive RUTF rations based on their body weight, but now all beneficiaries in OTP receive 2 sachets per day. And we also started discharging after meeting discharge criteria for 1 visit only, instead of waiting 2 consecutive visits, because they received the double ration, so we discharged it in the first visit. There are 2 activities only suspended for the time being. The community level screening by community nutrition volunteers. This is because of mothers refuse to send bees to measure their children because of fear of COVID-19. And also from our side, we decided not to really to prevent the transmission in the community. The second activity we suspended is mother-to-mother support group sessions, since the gatherings are banned. So this is also suspended for the time being.
Well, you've been busy, Lubaba, delivering and adapting and keeping the show on the road. And in doing that, could you take a few minutes to really touch on some of the key areas that have gone well and the things that haven't gone so well? And when we've had our conversations, there's been many things that have gone well. And so really, what are the headline ones for you on both counts?
Okay, actually there are many things gone well, and there are also some still we're really trying. Let me start with the positive one. I can say the coordination part is really strong in the country. The Minister of Health and the Nutrition Cluster were very active in promoting adaptations. The first guidance was out before the first COVID reported in the country. So that really helped us, gave us time to prepare ourselves and also to train our staff. Concern headquarters also developed a detailed guidance that really helped us to ensure the adaptations. That includes the triage and site setup. That also helped us a lot. Concern is also an active member of nutrition cluster that also helped us to contribute on the revision of the guideline and also to adapt the recommendations in all sites timely. Adaptation of family MOAC, I can say that's also one of the activity gone well because most mothers now they can measure their own children's MOAC. So that's one of the activity. So far, no suspected cases identified in our nutrition sites. That is also the good thing. Otherwise, maybe the situation might be different. Preposition of supplies, that was also one of the good things from our side. When there was access restriction, since the supplies were prepositioned, staff provided services to the beneficiaries without any interruption. When there was shortage of face masks, Concern also managed to use a tailor in the camp to make clothes masks and distribute to our staff before we get other supports. But later, WFP provided us face masks for staff and for CNVs as well. And UNICEF also provided us with hand sanitizers. On behalf of Concern, I would like to thank actually WFP and UNICEF for their support in the country, and USAID, OFDA for their flexibility to approve our budget realignment, to procure some of the PPE, because when this problem happened, there was no budget to procure PPE. So OFDA allows us to realign our budget, and we managed to procure some of the essential PPEs, I can say. Some of the points I can add also, some hasn't gone well. There was challenge with the PPE at the beginning, even it was not available in the country, even in the market. And also the small amount available was prioritized for health workers. So that was one of the challenge we had. There was some confusion on how to isolate suspected cases. If there are suspected cases in the nutrition center, how can we isolate them and how we refer them? This was also one of the challenge. But luckily, so far we haven't identified any cases, and we did not face challenges. The drop in we also observed a drop in admission as presented earlier. Since we shift our admission criteria to MOAC and ODIMA only, so some children are missed actually, those who are fitting the criteria of weight for height safety score. So this can be the reason of removing the weight for height admission criteria, even suspension of the MOAC screening at community level. And also some fathers also refuse mothers to take their children to the nutrition center because of fear of COVID-19. But from July, we observed also some improvement in admission. I think community also understand, they have also confidence in our staff, especially when we have really strong IPC measures. So staff started screening at community level, and beneficiaries also coming to the center, and the family MOAC also improve our admissions. Initially, mothers were not interested to take the responsibility of child's MOAC measurement. That also makes actually the distribution flow a bit slow, but later it was improved. Mothers with OTP beneficiaries were complaining on the RUTF ration change. You know, previously they used to receive RUTF based on their body weight, maybe 3 sachets, 4 sachets based on the weight. But now everybody in OTP are getting 2 sachets per day. I think these are the points.
Fantastic. Thank you, Lubaba. You've covered a lot of territory there in a short time. So just for the last few minutes then, I wanted you to, could you just touch on what are the key outstanding challenges that you're facing or questions you have emerging from your experiences so far?
Yes, we have actually challenges, especially in South Sudan. You know, there are lots of challenges. Referral mechanisms are still a challenge because isolation centers are the state's hospitals, so infrastructure is not really that much strong, especially arranging transport for suspected cases. These are not really clear. Although Minister of Health and WHO are working to establish testing centers in different states, but currently we have only 1 testing center in the capital. So that also affects the testing capacity. Some caregivers still, they are not bringing their children to the health facility to the level we would expect. It is because of fear of COVID-19 and also less screening at community level. So one of the main challenge we have is there is no clear guidance on mother-to-mother support group sessions. We suspended for the time being, but we are still waiting guidance how we can really continue. Challenge with the supply of MOAC bands. As we mentioned, the family MOAC approach we need really many more bands to train all mothers with children under 5 in the community. We understand there is local production in the region, is planned by UNICEF, and UNICEF South Sudan also expecting some stock, but not sure when they will arrive in the country. Otherwise, we are still waiting for more tips. Lack of face masks for community members to use in public places. When beneficiaries are coming to the nutrition side, they are coming without face masks. So that's one of the challenge. In some area, in some nutrition sites, we have limited waiting area. That is really a challenge to maintain the 2-meter distance. So that also affects our program. These are the challenges we have so far.
Fantastic. Well, you seem to be weathering them well. And related to that, maybe we're nearly out of time, but if you could take the last minute or so, just to share, what are your top plans for in the immediate future, your next steps that concern, maybe your top 3 or 4 things that you're planning to do?
Okay. Actually, the adaptations will remain in place for the near future, but we also expect some revisions based on the lessons. There will be some revisions as well. We're looking to reactivate the community level MOAC screening. There is also a guidance from the nutrition cluster by using proper IPC measures. Community nutrition volunteers will start the screening. We are planning also to reactivate the mother-to-mother support group, but still we are waiting for guidance. Promotion of family MOAC will continue if we get the MOAC band supply. We'll continue also to monitor the admission trend. As I mentioned, there was a drop in admission at the beginning, but now again started improvement. So data collection and analysis to understand more the situation, especially comparing the 1 visit discharge with the 2 consecutive visit discharges. We are really worried if that will increase the relapse rate. To document and share learnings as well, and write up this case study will be also available soon from Concern. Thank you.
Lubaba, thank you so much. Very, very interesting and so well delivered. Alison, quickly checking any clarifications, or are they all discussion points popping in?
All discussion points for now.
Brilliant, thank you. So over to Martha.
Thank you, Lubaba. Thank you, Mary, for such a wealth of experiences shared. Just to remind the participants, please keep the questions coming in the Q&A. This is more than anything an avenue for the different organizations planning to implement the adaptations to really ask as many nuanced questions as possible so as to help them better implement once they get to start. We will now hear from Sadiq. Sadiq is the head of the Nutrition and Health Department for the ACF Somalia mission and is based in Mogadishu. Over to you, Sadiq. Hello, Sadiq.
Hi, Mother. Good afternoon, everyone.
Hi. Welcome, welcome. So, would you please tell us a little bit about the program currently in Somalia? What are you doing? What programs are you engaged in? And what is happening that is different from previous? What is happening in the current COVID context? Okay.
So in Somalia, ACF has been operational there for the last 3 decades. We provide integrated life-saving health, nutrition, wash, food security, and livelihood services. We are also engaged in some longer-term resilience building and system strengthening initiatives. In Somalia, we work in 4 regions, that is Mogadishu, Banadr region, Lower Shabelle, Bakol, and Ail in Puntland. So in Banadr, which is the area where we're having this case study, we are working in IDPs and poor urban host communities. Our nutrition intervention in Banadir is working through the existing Ministry of Health structures, and we work towards strengthening the existing structures through providing technical support to the government, and we run through government facilities. On COVID-19, we have had the first case in Somalia in March, and presently we have 3,220 confirmed cases with 93 deaths. We're also one of the main actors in the COVID response, supporting the only treatment center in Mogadishu through deployment of staff, capacity building of the staff who are working in the treatment center, provision of medical supplies, PPEs, equipments, in addition to providing logistical support, and I think ambulances for referrals to the COVID treatment center. In the context of COVID-19, there have been restrictions imposed by government, and I think additional directives to be able to control the virus, which has had an impact on the programming that we were implementing. Additionally, what happened is most of the private facilities, private healthcare service providers in Somalia closed down their facilities, that making the public facilities which we supported the only point of call, because the private healthcare providers thought that they didn't have adequate protection for their staff and made the easier choice to be able to close down. So we continue to support the treatment center. The other bit is the numbers I've mentioned may not be a reflection of the true picture on the ground, considering that there is limited testing capacity, which is only limited to the major towns. So you may be having numbers higher than that, which are not being tested.
Thank you very much. Just a quick question. You talked about the private facilities being closed. Do the private facilities also provide nutrition services?
Okay. Now, the private facilities mostly provided the other component of health, which is the primary and secondary health care. They don't provide nutrition treatment services, but what is happening is the facilities we support are integrated, providing health nutrition services. So the closure of the private facilities resulted in more beneficiaries coming into the facilities that we support.
Okay, great. Good. You've talked about the various challenges you faced and how you've managed to contribute so much to whatever is happening in the country. So I was wondering, what are some of the adaptations you have made to keep the services going? Are there any services that were stopped? What were the changes? It's just about 4 minutes.
Okay. So we have made adaptations, and I think the objective of the adaptation, as you mentioned, is number one, to ensure continuity of the services, but also protect the frontline healthcare workers and the communities that we serve. And part of the adaptations we made is, like in South Sudan, we initially adopted a work-only approach at admission, and we had to review that after 2 weeks. We initially stopped weight for height measurements because we didn't have adequate PPEs for the staff. We didn't put in place adequate protocols, infection prevention measures in the facility, but we were able to revise that after 2 weeks and restarted taking weight for height measurement. This was only possible because we received PPE supplies, which we were able to give to the staff at the facility. We were also able to establish adequate IPC infrastructure. In addition to that, we were able to develop some disinfection protocols for the anthropometric tools, such that after every measurement, we have had the weight and the height boards disinfected. And this was thoroughly manned by community health workers. Most of the other partners, through the guidance of the nutrition cluster, continued with only MWAC admission, but we were able to restart the MWAC admissions, the weight for height admissions after 2 weeks. Another adaptation that we made was we were able to establish triage at the entrance of the facilities and basically conduct screening for all people coming to the site, taking their measurement with an infrared thermometer and flag out any person or beneficiary who had higher temperature than normal. Those who had higher temperatures were taken through additional triage and investigation to be able to determine whether they met the case definition for COVID-19. Those who had met that were promptly referred to the COVID-19 treatment centers through a helpline, which was provided by the government. Those who didn't were isolated and treated within the facility. The other bit with also the triage is, fortunately, we did not have any wasted children who tested positive or who met the case definition for COVID-19. Another adaptation we made is we reduced the frequency of the visit from 1 week to 2 weeks for some children. And we also implemented an appointment-based service, and that was to ensure that we have at least a maximum of 20 beneficiaries at the site at any point in time, because that was a directive from the government that they do not want to see more than 20 people gathering at the facility. How we were able to maintain this is we gave people coming to the facility appointment schedule so that each person will come in within the time given in the appointment. We were also able to, as I mentioned earlier, put in place adequate IPC infrastructure, putting in place hand washing stations at strategic points within the site, and provision of soaps. These hand washing stations were also manned by CHWs to ensure that there is adherence to the prevention measures that have been put in place. Another adaptation through the nutrition cluster was we were able to introduce Rapid Pro because of the limitation in terms of monitoring and visits to the facility by the program staff. We introduced Rapid Pro, which was a mobile-based application, which was able to monitor the service being provided in the facility, to be able to track if there were any challenges with supplies, if they had adequate MOAC tapes available, if they have supply shortages, if there are any of the staff who have exhibited symptoms of COVID-19, so as to be able to provide real-time support to the facility. Some of the services that had stopped and we were not able to continue is we had to suspend the community outreach services and screening by community health workers at community and household level. This was basically to reduce exposure for the CHWs and also limit infections in the community. And instead of that, we were able to scale up and adapt the family MOAC initiative. So the challenge with the family MOAC was the uptake for that wasn't really well, but I think it substituted for the suspension of the community level and the outreach and screening services. Additionally, I think in terms of the services that stopped is we were not able to also continue the BCC IYCF component of the project.
Thank you so much.
The SAM treatment service. So that was another thing that we were not able to continue and has had to stop.
Okay, thank you. It's good to see that you've had all these adaptations. Would you also take us through what you think has gone well and has not gone well so far?
Okay. What has gone really well for us is we were able to maintain the services that we were providing, which were very critical. And except for the outreaches, I think we maintained the fixed services that we have been providing. The other bit is the reduced frequency of the visits for, I think, the Western program reduced the burden on the staff, and I think they were able to serve the beneficiaries longer because we were only having 20 beneficiaries in the facility at any point in time. We were also able to limit the, I think, transmission of the virus among the beneficiaries we served, and also the frontline healthcare workers that we were working with. The other bit is we were able to preposition health and nutrition supplies. So we didn't have any stock out of essential supplies during this period when we were doing the adaptations. Another thing that also worked very well for us is we were able to continuously orient, sensitize the staff on the adaptations, because COVID-19 was something which very little was known about initially, and I think there were emerging information every now and then, and we were able to do this through webinars and virtual training sessions. What did not work well for us is we have had some challenges with PPEs initially, because I think it wasn't available locally in Somalia, and there was also a lot of demand in the global and regional markets. So we had to run, I think, for quite a while without essential PPE supplies, which put the staff and the communities we serve at risk. The other bit is we have, because of the adaptations we have made, I think, and because of the suspension of the outreach services, we have seen an increase in the length of stay and a reduction in the average weight gain for the beneficiaries or in the SAM treatment program. We were also able to observe a slight increment in the number of defaulters, and this was linked to the reduction in the outreach activities and the fact that we were not able to do home visits and follow up by the CHWs. One particular challenge we had in one facility is we were not able to do crowd control and be in line with the government directive of having 20 beneficiaries in the facility. And we have had to close down the OPD section of that facility and prioritize inpatient services and critical maternal and child health services. So that has also been a challenge that we saw.
Sadiq, I'm sure there's quite a lot that can be shared. Would also want to know a little bit more about some of the challenges you are facing. I know you've talked about a couple of them previously, but maybe if you could go a little bit more into details on some of the challenges you're facing or some specific aspects that are being affected by your experiences currently in making various adaptations to the program.
Okay. One challenge we saw is we have had low uptake of the mother-led work initiative. And basically that is because capacity at community level for the caregivers to be able to continue that is not very good. And this is linked to the fact that we are not able to do physical trainings, but also guidance and mentoring or follow-up to the caregivers at household level. Another challenge we have experienced is communities shying away from the facility because they have the perception that the facilities is a point of contamination or contact with the virus. So because of that, we have seen people who were avoiding coming to the facilities, and we saw less numbers than we have been seeing previously. The other challenge that we also see is misconceptions around COVID-19, and I think the uptake of the risk communication and community engagement strategies at community level, reducing the possibility of us resuming the outreach services. So those were basically the challenges or things that we foresaw.
Thank you. I would like to hope that COVID-19 situation is not going to remain as it is. So what are the plans for the immediate future, or what are the next steps?
Okay, in terms of the next steps, I think we are a little bit cautious to get back to normal. And what we will be doing is we'll be continuing to, I think, have the adaptations that we have put in place. Additionally, I think we will monitor the situation to be able to determine when it will be very fit to go back to normalcy. In addition to that, we are looking at procuring and sourcing additional PPE equipment so that we're able to provide the community health workers with PPEs. I think with PPEs, we should be able to at least have some bit of confidence with the resumption of the outreach services. One other thing we're also looking at is we are looking at, through our WASH intervention, establishing adequate IPC infrastructure at community level. And I think that will allow us to be able to resume some critical community level services such as the BCC, IYCF activities, and also the community outreaches and the community health worker activities. In addition, I think we're looking at doing capitalization on all these adaptations. I think reflect on what has worked, what hasn't worked very well, so that we're able to embed this within our routine programming.
Thank you once again for sharing your experiences. I'm sure there's a lot more to share, and a lot more will also be shared in the Q&A session. We're now going over to the Q&A session, and I'll hand over to Marie. Thank you.
Great, thank you. Well, I know everyone is eagerly popping lots and lots of questions on the Q&A, and we've been answering some of them offline, and the interpreters have been busy translating those multiple language questions coming in. So without further ado, let's crack on with those. Alison, do you have a few questions to get us started? And as I say, these are questions open to all the panelists, to Lubaba, Sadiq, to Heather, to Saul, and to Zita, who presented as well.
So the first question is for Saul. So it's a comment that there does not appear to be adaptations related to prevention. So it's just wondering if you could comment on that.
Yeah, so maybe those are less visible in the guidance, but there are a range of specific measures that are included in the first section of the guidance that look or that focus exclusively on the question of prevention and how a range of services for the prevention of wasting can and should be adapted to deal with some of the challenges of COVID. As I said, maybe it's less clear because of the way it's presented. It's less clear what the adaptation is from what to what, but the list of things that are included in the table under section 1 all capture WHO guidance on adaptations to prevention. So yeah, there is, that's sort of everything that is listed in there sort of summarizes everything that is already out there on the subject. Over.
So thank you. Just to clarify then, which might relate to this question, is for the adaptations that you reflected on, that you're finding, that you're documenting across the countries, they all seem to be regarding treatment.
I see. Okay. Yeah. So on the mapping side, yeah. Sorry, yes. My bad. I thought you meant in the guidance. So yeah, look, yes and no. I mean, we are doing a similar process for mapping out both disruptions and adaptations across the world. For all nutrition services, and of course those include both early detection and treatment as well as prevention. What I presented today, which is a subset of the work that we're doing specifically on early detection and treatment, but a similar effort is being implemented right now on the prevention side, and I'm happy to sort of work with you all in sharing the outcomes of that effort after this, but yeah, it wasn't presented today, but that information is available. Over.
Great, and I think this again is a call for people to share their programmatic adaptations across wasting management, and so we'll be very eager to hear from them, as I'm sure Heather would be, and that team. Alison?
Yeah, so there are a few questions related to family MUAC, so I think we can probably combine those, and these would be for Sadiq and for Lubaba. So for the family MUAC approach, there's a question around which tapes you're using. Are you using the coloured tapes or the MUAC tapes with numbers? There's a question around how you trained mothers on family MUAC. Was it a face-to-face training? And then asking whether it's a temporary adaptation or whether you think it will remain a new normal to screen children over.
Great, well, great questions. Maybe Martha, you could start. Sorry, not Martha. Lubaba, you could start first, and then Sadiq, you can respond to those three too. So Lubaba, you first.
Okay, thank you. Regarding the type of mark we are using in South Sudan is the color coded mark with numbers. But we encourage mothers only to use the colors, not really the number, because most of them are illiterate, so they don't need to really read. But if they understand red is severe, yellow is moderate, so they can just screen based on that. Regarding the training, we train mothers using dolls because currently we are trying to avoid touching our beneficiaries. So our staff, they use dolls to measure mark, to demonstrate. Then staff ask the beneficiaries also to demonstrate in their own children. So then that's how they learn. When they're coming to the site, they're coming with their mark tips. They're the one also measuring their own children. Then the staff are also supporting them in case of any challenges. It's not easy at the beginning. Mothers were not really comfortable to measure their child's mark, but later they really understand, and now they are measuring their children's mark well.
Great, and Sadiq, from your side, what's your experience here?
We are using the color-coded tapes, but because of initially we're running a pilot phase of this, but we have had to scale up because of the adaptations within the pandemic, and the additional mock tapes that we are providing were not only the color-coded, the ones with the numbers. On the trainings, we were doing, I think, trainings within the facility, and the caregivers were practicing with their children. One challenge that we have had with the uptake is, I think, there is no regular monitoring at household level, and most of the time you get referrals at the facility, which are measurements wrongly taken. So previously, I think with the CHWs were able to do monitoring and be able to make corrective measures in terms of the measurements that were being taken. This is one challenge that we have. The other bit is for mothers whose children are in the program, I think the uptake and adaptation of this is really going on very well. But where we have challenges is caregivers whose children are not severely or moderately malnourished, who are supposed to be doing the routine screening at household level. That is where we are seeing some bit of challenges. And for those ones, we are looking at doing household visits for mentoring, considering social distancing and all that. And with practice, they're using their children to be able to practice the measurements.
Great, thank you, Sadiq. Martha.
Thank you very much, Sadiq and Marie and Lubaba for your responses. Alison, do we have any more questions?
Yes, we have many questions. So there was a question on the guidance. So I guess this would be for Saul and Zita. There was a comment that in the guidance, it is advised that you can take weight even if PPE isn't insured. So we just wondered if they could explain a little bit more on that.
Sure, Saul and Heather, maybe you could take this on as Alison says. These are very practical questions and people really would like to get what is practically possible within the different contexts.
I'll say something, but I think this might be worth bringing in Zita in for. I think that what the guidance says is that it's not. I don't think it's a binary yes or no answer to the question of weight in the absence of PPE. There's a sort of a gradient of situations here, primarily in the sense of, for example, can some of the tools for weight measurements, the weighing pans and the like, be sort of disinfected regularly enough? Do we have scales that would sort of prevent having to use of the weighing pans? So I don't think it's a yes in all circumstances or a no in all circumstances. What we're trying to do in the guidance is to give a sense of what are some of the considerations that people need to keep in mind. But I don't think that that's I think that the guidance is less categorical about how to proceed in the event of limited PPE. But Zita, do you want to weigh in on that?
Yes, maybe I can just add to what you said, Saul. Well, the point is that weight for age can be an important indicator to identify nutritional risk in infants. And the point is that if digital scales are used and infants are carried and mothers or caretakers carry the infant and step on the scale, that can be used even with limited PPE in place. So again, as Saul said, it really depends on the setting, but the options are there for this to continue. Over.
Thanks, Zita. Alison?
And there's a couple of questions on whether we have any program data on the impact of adaptations, especially in terms of length of stay and weight gain.
Yeah, I think Heather would be able to answer this question. Heather, over to you.
Sure, I can speak from the Adaptations project. We have started to look at some preliminary data, mostly from Action Against Hunger's programs that have implemented modified follow-up schedules. We do see increased length of stay. In most of the programs, we have seen increased defaulting. And in some of our programs, including Somalia, and Sadiq, you can please follow up if there's additional comments, we have seen less weight gain during treatment. It's tricky though, there are a lot of variables at play in the context of COVID-19, so there's lots of factors at play here. So it's not quite clear exactly what might be causing these things, but just to see some of these outcomes, it certainly causes for us to take a look and be mindful of what's going on with programmatic outcomes in terms of length of stay and weight gain.
Maybe we could add Saul to give us any additional information with that, as UNICEF really has a much more expanded platform to be able to get information from the different countries.
Yeah, no, I think Heather is spot on. I think that some of the changes that we're seeing in performance are certainly around length of stay, defaulting, and weight gain, but a lot of that remains, I mean, anecdotal might be the wrong term, but I think not sufficiently documented for us to be able to build a sort of a comprehensive answer as to why and how can we effectively address that in the particular context that we're in. But that's precisely where the initiative that Heather presented comes in. So as we have said before, if you're in a position to share program data, that will be supremely helpful to us. Our goal now is to be able to put all our sort of technical capacity, our combined technical capacity at UNICEF, ACF, and CDC, precisely at the service of answering these questions. But in order to successfully do that, we're going to need all the data we can get. Over.
Thanks, Saul. Alison, more questions, please.
Yeah, a question for Lababa and Sadiq. A question around how MAM children are managed. MAM children with complications. Are they referred to a stabilization center or a pediatric ward? And also, do they receive nutritional support in addition to medical treatment?
Okay. Regarding the MAM children with medical complications in South Sudan, according to the national CMAM guideline, children with medical complications are referred to pediatric ward, not to the stabilization center or inpatient care, because they don't need therapeutic milk or other medications, but they need just to resolve the medical problem in the pediatric ward. So we are referring them to the pediatric ward, not the stabilization center. But when they come to the nutrition site, they receive their rations when we refer them. So they go with their own ration, so they can still use the rations when they are admitted in the hospital as well.
Thank you, Lubaba. Alison, any more questions? We can go through within the remaining time.
Yeah, there's one. Is there any experience on how the costs incurred during COVID-19 adaptations for CMAM programming when compared to non-COVID?
I think that's a question that's open both to implementers in the field, but also to Saul and Heather and Zita. So maybe we can begin with Saul, and then all the other presenters can come in.
Yeah, I don't think we know. That will be the long and the short of it. I think that there are, there's reasons to think that some things we might be incurring savings in some areas, but I think that there's also plenty of reason to think that we are incurring higher costs in others. What I would say is that overall the cost effectiveness is probably negatively being affected, given that effectiveness is being affected. So I think that what we need to continue to focus on is not just costing, but cost effectiveness, because that feels like the right ratio to be tracking over.
Good. Thanks. Any other presenter would like to add something?
Yeah, this is Heather. Just to reiterate and note that we are hoping to explore some of that with this adaptations project as best we can. And to note, as Saul said, some of the preliminary work information we're receiving from the field is that those costs vary according to context. So I think Saul's note around taking into account the effectiveness is going to be key.
Great, thank you, Heather. I'll give you a bit of a breather, Martha, and unfortunately not give you a breather, Alison. Any more questions coming your way? And take a moment or two if you just need to kind of scroll down and get a handle on what's popping in.
So there's one here on MUAC as admission criteria. What to use for the monitoring and progress of children. And basically the questions around how do you understand, what criteria do you use to declare that a child is not responding to the treatment?
Okay, so perhaps Zita, is that one you'd like to take on?
Well, it's it's a good question, of course, and it's something that we would also like to hear from you all who are using a MUAC-only approach. How do you monitor recovery in terms of sort of daily recovery? I mean, WHO does recommend if MUAC is used as an entry criteria into a program, MUAC can be used as an exit criteria in terms of discharge from the program. But what about monitoring sort of the daily improvements? Of course, the recommendation is to use weight, but I'm not sure how this is actually being done when countries use the MUAC-only approach. So it's actually back to the ones who are doing it.
Exactly. Well, maybe Sadiq, from your experience, how are you managing MUAC on that front? Do we still have you, Sadiq?
Okay.
Oh, there we are. Thank you.
Okay. So initially we adopted the MUAC-only approach, and it's only after 2 weeks, I think, we introduced the weight for height. The follow-up for MUAC is we're looking at, I think, the average length of stay, which is 8 weeks, and seeing at least the MUAC at discharge, which will be above 11.5 for 2 consecutive visits. So if we don't get that for 2 consecutive visits within the 8 weeks length of stay, that is when we declare a child to be non-responsive.
Great, thank you. And Lubaba, from your side.
Okay, thank you. Regarding the MUAC admission, if beneficiary admitted by MUAC, the discharge criteria will be also MUAC. even before COVID-19. But before COVID-19, even if they are admitted by MWAC, we used to monitor their weight. Every time when they come to the center, we measure their weight, and also we calculate the average weight gain at the end of when they recover from the program. But currently, since we dropped weight measurement, so the monitoring will be also MWAC screening, MWAC measurement. It's not easy like weight measurement because progress in MWAC is really slow. You can't see really that progress in a short period of time, but that is the only option we have currently. So monitoring will be also using MWAC. Thank you.
Great, thank you both. And just spotting a question that's coming on the chat as well is regarding the inpatient management of SAM services. I think we've been referring a lot, particularly I think to community-based management. And in both your experiences, Lubaba and Sadiq, has inpatient treatment services, access to them, or indeed availability of them, being reduced in the context of COVID-19? Maybe again we can start with you, Sadiq.
In our case, we have maintained the same level of service provision for the inpatient management, because in addition to the OTPs, we also run stabilization centers, and we put in place some adaptations to be able to ensure the continuity of that service. And part of that was, I think, ensuring that there is a 2-meter distance between the beds, ensuring that you reduce the number of visits by other family members except the primary caregiver who is with the child at the stabilization center. But what we have been able to also do as a modification is put them on stabilization F100, and instead of F75, I think start them on Plumpinat and refer them to the OTP sites once they are stabilized. So that is adaptations we did to be able to ensure that we are able to continue that service. In terms of access, I think we have seen increased number of children in the stabilization center and needing inpatient management during this period of COVID-19 as opposed to the previous caseload that we are seeing. We are attributing this, I think, to the low community outreaches, the community screening that's happening, because previously we were able to identify these children early enough and refer them to the outpatient treatment services. So in the absence of that, we are only getting them when their situation deteriorates and they require inpatient treatment.
Great, thank you, Sadiq. And Lubaba?
Actually, Sadiq already mentioned most of the points, but what I can say in the inpatient services, the IPC measures are really strong this time. As he mentioned, we are not allowed other people coming and visiting while they are in the inpatient care. And also, government of South Sudan, especially Minister of Health and the nutrition cluster, they are trying to integrate the isolation centers with nutrition services. So Minister of Health staff will be trained on inpatient care management in case if there are suspected or confirmed cases of COVID from the nutrition centers. So it's actually integrated now. So even if they are confirmed, they will get nutrition support while in the isolation center.
Great, thank you, Lubaba. Alison, more questions?
Yeah, a couple more coming through on the family MUAC approach. So I think we can probably ask those together. One question on those doing family MUAC, are mothers able to measure and find the arm midpoint, or do they just judge it by eye? Do they just guess the midpoint? And then a second question was on when you use the dolls for training, what size are the dolls? What kind of dolls are you using? Over.
Okay, I can give some input on the family MWAC part. As I mentioned, most of mothers are illiterate, so it's really difficult for them to find the center and mark the center. But when we train them, we usually show them how to find the center by measuring with a thread without even bending the MWAC tape. So they find the center, then they put their finger in the center, then they measure that place. But there is no marking with pen or like what we are doing in the center. Regarding the dolls, we usually have dolls in the nutrition center for child-friendly spaces, like 2-year, 3-year-old dolls. So we use that one just to demonstrate, showing how to find the center and also how to measure MWAC using dolls. The objective of using dolls is like to apply the no-touch approach with our beneficiaries.
Thank you, Lubaba. And Sadiq, anything you'd like to add?
No, I think in terms of the dolls, we weren't using dolls to be able to do the measurements.
Fair enough, that's great. I think, Martha, I'll just hand over to you, maybe just to handle the last 1 or 2 questions, I think, for our Q&A.
Thanks, Marie. Alison, what are some of the last questions we have?
Sorry, I was on mute. There's a question here for Saul. What adaptations have been taken for capacity building of healthcare workers in the context of COVID-19?
Yeah, it's a good question. I think we have done perhaps less a concerted effort in tracking that, to be frank. But what I can tell you is that there's a couple of things that we are really focused on right now. Is one, documenting and really supporting everything that has to do with more digital ways of communicating information and building the capacity of health workers on key sort of nutrition actions and services. So that we're seeing more and more a shift towards that. Some of the work, and I mean a shout out to the team at the International Rescue Committee who have been looking into this, like limited physical contact and building the capacity and building protocols for sort of limited physical contact as they do some of these sort of anthropometrics and the engagement with caregivers is also a big part, of course, of the measures that are being introduced right now, and that does require some adaptations in the capacity building efforts, and that has been documented, I think, in particular in the recent guidance on the work with CHWs and the treatment of wasting, and the webinar that was previously held. So there's some work there, both on the digital and the limited physical contact side that has been positive, and that work continues. Just to say, on the family MWAC, we're currently working with a team at ACF as well in generating some products, digital products, to support health workers in knowing how to build the capacity of caregivers in the use of MWAC without having, again, with limited physical contact and maintaining social distancing and all of this. So yeah, that's where we're at.
Thank you, Saul. Thank you. We have a couple of more questions and a little bit more time left. We can have a few 2 or 3 questions and then close the Q&A. Yes, Alison.
There's a question here from Indonesia saying that based on their protocols, they've been asking caregivers to have physical distancing, but also to wear face masks. But they're finding it quite difficult to actually get. They're actually having quite a bit of difficulty in making sure visitors keep to that protocol. So they were just wondering if people had ideas on strategies or experiences with implementing these sorts of protocols.
Thank you. Just a question from the French section. We had someone ask, and I think this is a question that would go to Lubava and Sadiq, if they have used the MOAC and ODEMA as an admission criteria, experiences with that, has it worked? Sadiq and Lubava, maybe we could begin with Sadiq.
Marta, can you repeat your question? I didn't get your point.
Have you used MOAC and IDIMA as the admission criteria? It's one of the recommended adaptations currently, or one of the simplified approaches that's being recommended, where we're saying, let's use MOAC and IDIMA for admission, follow-up, and discharge.
Okay.
Yes, Lubaba.
Okay. When we were talking about MOAC and ODEMA, both criteria are different criteria. If a beneficiary fits in one criteria, the beneficiary is eligible for OTP program especially. Or if a child has ODEMA, that child is severely malnourished, so the child will be admitted in OTP, regardless of the MOAC measurement. Even if MOAC is 16 or 17, the child can be admitted in OTP. And also, if the child doesn't have ODEMA, then we measure MOAC. Then MOAC cutoff is different for OTP and TSFP based on that criteria. Beneficiaries will be admitted based on one criteria only. But when we come to the discharge, if a child is admitted by ODEMA, discharge criteria will not be only ODEMA. We check ODEMA, even if ODEMA is subsidized, we have to check again MOAC. If MOAC is still below the criteria, that child should stay in the program until the MOAC cutoff reaches for the discharge. I hope I answer your question.
Oh, thank you. Sadiq, in the last 1 minute.
Yes, initially when we stopped the weight for height, we're using MOAC and IDIMA as a criteria for admission. I think with follow-up, IDIMA is an additional complication which will go with the initial treatment, but the key follow-up during the treatment process is we were using MOAC. One thing we tried to do is see if the caregivers are able to also do the IDIMA check at household level, jointly with the family MOAC initiative, but that did not work out very well because the IDIMA checking process and how they were checking was not correct, and they kept in sending to the facility children who didn't have IDIMA, but the reason for referral for them was IDIMA.
Thank you, Sadiq. Thank you, everyone. Thanks to all the presenters and the facilitators. Thank you for the time. We're coming to the end of our webinar. But maybe before we go, I'd like to hand over to Marie to give us a brief on what we've gone through in the next steps. Marie, over to you.
Thank you, Martha. Well, I think this has just been a fascinating webinar, and I know we could stay on for many hours, but unfortunately we can't. So I think we've heard some great detailed experiences, both from Somalia and South Sudan, and great directions of travel at a policy level, with WHO and UNICEF's implementation guidance on adaptations, and then a really great initiative to sort of capture the programmatic adaptations and as Heather emphasised, not just what we're doing, but how we're doing it and the implications of what we're doing. So I really would encourage you all to contribute to that effort, that collective effort, and I think, as well as the nature and the implications, or part of the implications of these adaptations, is we need information on what the burden of care is and what the implications are of COVID-19 for nutrition. And we've seen recent publications of projections of increased caseload. And so we really need to be amassing the evidence of how it's looking on the ground. And I think with these adaptations that we're having and needing to do, sometimes it's quite tricky to get this data, because as you adapt, it's harder to interpret what your admission figures mean. And we also, again, just don't have that access to be surveying. So I think the more qualitative experience on the ground, eyes and ears that you all have, is really, really critical. And we need to be capturing what is happening and the increased numbers or burdens you're seeing. So please do contribute to this initiative, and ENN as well, in our support to knowledge management of the Global Technical Assistance Mechanism on Nutrition is keen and interested to help capture and document experiences. So please contact any of us in this regard. It struck me that the PPE and access to adequate and resource supplies of PPE is essential to keep our services on the road, and is necessary to facilitate both adaptations and sustaining what is there. And many of the countries have, and the programs have these experiences of the physical distancing that is necessary. But still encouraging, enabling the social cohesion that is really necessary in communities to get through this. So a big thanks to everybody for participating, all the panelists, to the interpreters who have been so solidly working and beavering behind the scenes, and to you all for engaging and asking so many questions. I'm sorry we didn't get round to all the questions, and indeed the one that Alison posed from Indonesia, but we will follow up on all of those. As I said earlier on, you'll get questions and answers, and we'll get escalated questions as necessary. So I will just hand over to Martha, who's just got some final closing follow-up remarks from the RT.
Thanks, Marie, and thanks everyone again. It's been wonderful. Maybe just before we go into how to get support, please do continue to use the COVID pages on the EN and the GNC websites if you have any questions or any experiences you'd like to share, in addition to the acutemalnutrition.org. So I know it's new experiences, it's new adaptations that we want to do, and definitely there's need for support. In case you need any remote or in-country support, if the travel restrictions are lifted, we have the Technical Rapid Response Team, or through other mechanisms from the GTAM. You can also hire a consultant directly. We do have pools of consultants available for CMAM, for micronutrient, for infant and young child feeding in emergencies, and those can be shared with you to get a consultant. If you also want quick technical advice, you can send your questions and concerns to the GNC help desk, at which point you will be given all the relevant information to go with. For any more information, please do go to a link shared below, which is the nutritioncluster.net, and you can get as much support from there. Thank you so much. It's been a pleasure having all of you, and have a good morning, good afternoon, and good evening. As you get off the webinar, you're going to be sent directly to a link that requires to do an evaluation of the webinar. The evaluations are very important to us because they help us to do better in the coming webinars. So please do allow to take a little bit more time, 10 minutes or less, to be able to complete that survey. For any additional information, please do contact the TechRT at International Medical Corps, but you can also visit our website on techrt.org, and we also do have a Twitter account. Thank you very much, and have a good remainder of your day. Thank you. Bye.
Goodbye all.